Good afternoon, everyone. Today we are going to have a discussion on practical points in pediatric refraction. So we have divided the topic into five subtopics, and we'll move on to each refraction. First, we'll be dealing with the basics of pediatric refraction. Refractive errors are the leading cause of visual impairment in children. Early detection and management is very crucial for the optimal visual acuity, binocularity, and overall development of the child. Any delayed or inappropriate correction can lead to reversible amblyopia, as well as it can impair the child's optical as well as neural development. So we all face unique challenges in pediatric refraction. So it's very difficult to attain a correct value. So we'll get a limited cooperation from the studied subjects. They lack the attention span. The values that we get will be of low reliability and they will be inconsistent. They have a greater accommodative range which masks the true refractive status of each kid. And it is always difficult to quantify the visual status, as we shouldn't forget the risk of amblyopia as well. So the visual assessment of any child should be age appropriate. For infants, we can follow the CSM technique, that is central fixation and steady fixation and maintenance. We can look for the movement assessment. Preferential looking charts can be taken into consideration. Any objection to occlusion testing can be taken, and fixation preference can also be evaluated. But in case of preschool children, you can look for you can take help with the Allen's picture chart, HOTV matching letters, Lee symbol charts, or alphabet recognition cards. In school-going children, we can have the adults techniques like Snellen's chart, Logmar's chart, etc. So it should also consider a comprehensive eye examination protocol, including Hirschberg test, cover-uncover test, extraocular motility cases in all cases, convergent testing, a complete strabismus evaluation, anterior segment, dilated fundus examination, as well as retinoscopy. So what are the indications of a cycloplegic refraction in a kid? Every non-verbal child, every symptomatic patient, that is symptoms of asthenopia are there. All young children, any cases with strabismus, all children who are suspected to have pseudomyopia or poor correlation of subjective refraction and their symptoms, all have to undergo a cycloplegic refraction. So these are the different cycloplegic agents that we commonly use. 1% cyclopentolate, which is a gold standard for routine pediatric practice. It has a rapid onset of action with adequate cycloplegia and fewer systemic side effects. 0.5% cyclopentolate is preferred in younger children, infants with minimal systemic absorption. Atropine 1% is usually reserved for specific cases where you are expecting a child with a severe esotropia where you want maximum cycloplegic effects and all. So these are the various comparison table of various cycloplegic agents available. As we know that atropine sulfate, the peak effect comes at 3 days. So the retinoscopy has to be done on the 4th day, and PMT has to be done after 2 weeks. And it has a Stoner's allowance of +1. Homatropine and cyclopentolate, the peak effect comes after 90 minutes. So retinoscopy has to be done at 90 minutes and PMT has to be done after 3 days with the Stoner's allowance as noted in the table. Tropicamide and phenylephrine are agents just used for mydriasis. It is having a very negligible cycloplegic action. So the CTC regimen is the most commonly used regimen nowadays in the OPD setup. So for CTC regimen, first you apply cyclopentolate 1% eye drop in both eyes. 5 minutes later, you put the second drop of cyclopentolate eye drop, and 5 minutes later, again one drop of tropicamide and phenylephrine combination, and you perform retinoscopy 45 minutes after the first drop has been instilled. So it gives comparable cycloplegia to 1% atropine and very easily followed regimen in the routine OPD practice. So when you compare the systemic side effects of these cycloplegic agents, atropine is having the most severe systemic side effects, including hypothermia, restlessness, irritability, tachycardia, flushed skin and all. Cyclopentolate, even though it is not having that much of a severe systemic side effects just like atropine, you should take into account the possibility of drowsiness, ataxia, disorientation, incoherent speech, all these things. So should be used in caution with children with neurological disorders. So this is a clinical guidelines for prescribing a spectacle according to American Association of Pediatric Ophthalmology and Strabismus. When we look into this table, we can know that myopia has to be prescribed only if it is more than -4 diopters in infants and up to 1 to 2 years, and you should consider prescribing myopia if it is more than 3 diopters in 2 to 3 years of age. Hyperopia without esotropia has a little leverage. You can wait till +6 diopters, but if it is with esotropia, it has to be corrected even if the value is +2 diopters in an infant. Astigmatism also has certain values followed by like 3, more than 3, more than or equal to 2.5, and more than or equal to 2 in the respective age groups. So this is a national consensus guidelines for correction. So it follows a similar trend, but the values are slightly on the lower side in our country. That is, myopia has to be corrected if it is more than -3. Hyperopia, in the previous year it was 6. In national consensus it is +4. And if it is having squint, that is esotropia, it has to be corrected even if the value is +1.5 diopters. So gold standard of objective refraction is always retinoscopy. It helps us to determine the sphere, cylinder and axis in a precise manner, very effective in non-verbal children and with limited cooperation as well. So what are the key considerations that we should take into account before prescribing a child? You should take a note of the dynamic refractive status, because the refractive status keeps on changing with the age and the growth of the eyeball. And you should give a priority to hypermetropia, because hypermetropia has a more chance of amblyopia. And myopia, if it is a minimal myopia in a toddler, it need not be corrected. But if it is significantly affecting the vision of the toddler, it has to be corrected. Amblyopia risk has to be taken into account for all the cases, and you should also look for a presence of strabismus. If there is a presence of strabismus, the full cycloplegic correction has to be given. So in hypermetropia, as I told, early correction is prioritized because it has the risk of refractive accommodative esotropia and amblyopia. And infants less than 6 diopters without any squint needs no correction, and even in older children, slightly under correction is acceptable without esotropia. But in case of esotropia, it has to be given a full cycloplegic correction, or in case of high AC biratio also full cycloplegic correction has to be given. And you should also consider giving a executive bifocals to control both distant as well as near vision. Myopia management, on the other side, you should always avoid overcorrection. You prescribe the least possible minus power to the kid. But if there is any intermittent exotropia, even if the myopia is very small, it has to be corrected. So myopia less than 4 diopters in infant does not require any correction usually. In preschool children, you prescribe the lower degrees for myopia to match their visual demands. And in school age, it has to be corrected to optimize the distant vision as well as the classroom learning. Astigmatism cannot be overcome by accommodation, so it also has this amblyogenic threshold. So cylindrical power more than 1.5 to 2 diopters has to be prescribed. And another thing is, pediatric population adapts well to or adapts easily to the cylindrical powers, even if it is a high cylinder, on contrary to the adult. So it can be considered prescribing early enough. And you should also consider the fitting thing in the spectacles regarding the astigmatic cylindrical axis. Anisometropia is again a high risk area. Anisometropic and hypermetropic anisometropia and cylindrical anisometropia produces more amblyopia. So a difference more than 1.5 diopters in case of hyperopia and astigmatism needs correction. In myopia, you can be till 3 diopters. If there is amblyopia, you should treat the amblyopia as well. In case of aphakia and pseudophakia, initial postoperative period, you should overcorrect by 2 to 3 diopters, and by first year, you reduce the overcorrection by 1.1 to 1.5 diopters, and long termly, you should convert into a bifocal lenses, so that there is vision at both all distance and intermediate areas. Thank you. So our next topic is by Mrs. Rosemary. She is working as an assistant professor, Medical Trust Institute of Medical Science, College of Optometry, Ernakulam. Over to you, ma'am.
Good afternoon, one and all. My topic is refraction in children with special needs. I'll be speaking about common ocular issues associated with children with special needs, certain adaptations or modifications that you have to make into your conventional techniques of assessment, and some case-specific considerations. Children with special needs have certain additional challenges apart from your typically developing children, like they may have communication barriers, sensory issues, motor disabilities, short attention span, etc. But the prevalence of ocular impairment is very high in this group, and it often goes unnoticed or undiagnosed because most of them think that it is very difficult to assess these children. But to my experience, I believe with patients and with modified conventional techniques and in familiar surroundings, no child is untestable. So I will start with assessing visual acuity. An ideal setting for assessing these children would be their rehabilitation center or their special school. And if you can get the assistance from their caregivers or special educators, that would be an added advantage. You may start assessing vision binocularly and introduce the test as a game. Once a child gets used to the assessment, then you can ask the caregiver to occlude one eye. A child may resist wearing a typical trial frame. You can use some fancy kind of trial frame, so the child may be curious to wear it. Then for assessing visual acuity, you can use preferential looking tests or some matching cards. Whenever possible, you should do a cycloplegic refraction. Home eye is preferred. And objective refraction may not be that easy. You may use loose lens or a lens rack. The first picture shows a lens rack. I personally use it. It's very comfortable. You needn't change the lens often. It has a series of power like in 0.5 steps on one side and 1 diopter steps in other side. You have lens rack for plus and minus. So it's easy. You needn't change the lens often. You can just use it as a rack. Then coming to specific consideration, specific cases, Down syndrome, this kind of children you get often in OP. Assessment is comparatively easy in these children when compared to other groups. They cooperate well. But the real challenge is in dispensing spectacles. Their flat nose bridge and small ears or their facial features may pose challenges in dispensing. So you can use customized spectacles like the one without temples, and the second picture you can see with an additional nose bridge which align with their flat nose. Good compliance is very, well-fitting spectacle is very important in good compliance to spectacle. Now coming to cerebral palsy, the child may have poor neck control, associated motor disabilities, speech delay, etc. In these kind of children, you should specifically look for refractive errors, extraocular motility issues, and in specific accommodative response and cerebral visual impairment. Keep the child in their most comfortable or stable position while examining. That ensures their cooperation. Then examination room should be distraction free and dynamic retinoscopy should be done all whenever possible. These children may have accommodative lag is highly prevalent in children with cerebral palsy. So most of the interventions or therapies are aimed at near vision tasks. When the child have an accommodative deficiency, during therapy sessions, while doing near work, they develop ocular fatigue or asthenopic symptoms, and these children may not be able to express themselves, so it presents as temper tantrums or inattention, or they don't like therapy sessions, etc. So whenever you feel there is an accommodative lag after performing dynamic retinoscopy, plus lenses has to be prescribed as single vision for near or as bifocals, depending upon the age and activities of the child. Then red flags that you should be aware of in cerebral visual impairment is the caregiver or the parents may complain that child have difficulty in identifying familiar people. That indicates a reduction in contrast sensitivity. So you should assess contrast sensitivity. Child may have difficulty with visual clutter. When too many things are shown and if you ask them to pick one thing, they may find it difficult. And child may have preference for objects which are moving. They may respond to objects which are shown on some side of their visual field. They have color preferences, or they may be more interested in familiar objects rather than exploring new ones. So coming to reduce contrast sensitivity, you can use in hiding heady low contrast test chart. And this is especially applicable for speech therapy sessions. When the child have a reduced contrast sensitivity, and if they find difficult to understand the facial expression, the lip movements cannot be read by the child, and that can affect the speech therapy session. So the solution is, if you find there is a decrease in contrast sensitivity of the child, you can advise the speech therapist to use a bold colored lipstick, or even if they are using an app, the contrast can be enhanced in the app during the therapy session. That makes them easier to understand the lip movements. Here, the child have problems with visual clutter. In the first picture, there are too much of information that the child finds it difficult to identify the main character. So you can mask the surroundings so the central characters can be highlighted. And even when you assess for visual acuity, you can use single optotypes so that clutter can be avoided. Then autism spectrum disorders. I think this is the most difficult group to assess because most of them are nonverbal, hyperactive, and poor attention span. But these kids are associated with accommodation convergence difficulties and refractive errors. Prefer a quiet room and don't use too much of light or sound because they get irritated when they are stimulated. So always make them comfortable so that they will cooperate. In case of intellectual delay or global developmental delay, high refractive errors are often observed, and it goes undiagnosed because nobody bothers to have an assessment. So cycloplegic refraction and appropriate correction is very essential so that they can cooperate well with their therapy sessions. Hearing impairment, when child have an hearing impairment, they always depend upon visual cues for communication. So refractive error has to be appropriately corrected so that they can perform well. And some cases may be associated with night blindness, so that also has to be addressed. In premature babies, you should expect high myopia, and the need for long-term regular follow-up has to be emphasized. In ADHD and specific learning disabilities, they may be associated with accommodation convergence anomalies, and some specific learning disabilities may be a presentation of high functioning CVI. So when you speak of high functioning CVI, in cerebral visual impairment, children may be associated with other motor disabilities. So they have a low function. Low function cerebral visual impairment means their visual processing is on the lower side, it's on the first side. In high functioning CVI, child may not have some disability. Maybe if you look into the history, child would have had some perinatal risk factors and the child had come out unscathed without any disabilities. But once they come to a school level or an academic level, they find difficulty in, like especially in geometry, writing certain letters. So it comes out as specific learning disability. In such children, you should assess visual motor skills also. In epilepsy and seizures, use hometropine. Avoid overstimulation during sessions because that might trigger seizures, and give breaks in between examination. So my key takeaways are: patience and adaptations will give you successful assessment results. Know the child's comfort zone. Use disability appropriate chart rather than their age appropriate chart, and give adequate breaks between the tests. Thank you.
Thank you. Thank you, ma'am. That is a very insightful talk regarding the practical aspects. So our next topic is by Dr. Aunshi Filamasan. She is mainly working as a pediatric ophthalmologist in Aradhana Eye Institute, Trivandrum, Precise Eye Care, Trivandrum, Geetanjali Eye and ENT Hospital, Trivandrum, as well as Shankar's Eye Hospital, Punalur. She'll be talking on the topic decoding myopia in kids. Over to you, ma'am.
Thank you, Dr. Anjana and Ksos for giving this opportunity. So let's go to the management. We all know what myopia is. So regarding the prevalence of myopia globally, it is mostly confined to the Southeast Asian countries, and it's predicted by the year 2050, 50% of the world population will become myopic. And whereas in India, it's the leading cause of visual impairment, but still, the prevalence of myopia in India compared to that of the Southeast Asian country is still less. So we know it's axial, it can be curvature, lenticular, and if it's more than 6 diopter, it's pathological. There are several risk factors associated with it, and that's what makes the management difficult. So ethnicity, family, genetic factors, excessive nerve work or increased screen time, and reduced outdoor activities plays very important role. So we keep talking about myopia. All the pediatric conferences we go to, we keep on saying, why do we need to monitor myopia? Why do I need to know all of these things? Because like Dr. Anjana has said, it's very difficult to detect in children, also reduces learning ability, poor scholastic performance, and predisposes to strabismus and amblyopia. And every diopter increase in myopia leads to increased chances of myopic maculopathy, retinal detachment, cataract, and glaucoma. So coming to the strategies, we have lifestyle modification, pharmacological interventions, optical and emerging research with repeated low level of red light therapy and 7-methylxanthine. Like Dr. Anjana has said, any kid coming to the myopia clinic or who comes for eye vision test has to be thoroughly investigated. We have to take detailed history, assess the family risk factors, do detailed orthoptics, binocular single vision, and the most important thing is we have to monitor the axial length measurements and keratometry besides retinoscopy. After that, glass prescription will be given like previously described. I usually like to follow them up after 3 months to see how they are coping up with the glasses, then as routinely after 6 monthly. So the main thing about myopia is all of us are having difficulty in monitoring the progression, and hence the impact myopia guideline was formulated, which was published in IJO in 2023. It says we have to identify through axial myope and map the risk factors, pick up those who are progressive myope by monitoring the axial length, and advise appropriate myopia therapy. We have to consult, and monitor regularly. Counseling is very important because the parents may not come back for follow-up. And if we know how to start any treatment, we should also know when to stop it. Hence, in our hospital, we do axial length monitoring of all the kids. Like 99% of the kids, we make sure we do that as long as they are cooperative for the examination. And once we start with anti-myopia treatment, which we'll come to later, we have to do a first follow-up at 1 month to see the side effects or if there's any adverse effects of whatever treatment we're giving. Then second follow-up at 6 months. A good response is said to be if there is less than 0.5 diopter, that is less than 0.1 millimeter in 1 year. Then we can continue the treatment. If it is progressing more than 5 diopter, more than 0.5 diopter in 1 year, then we have to think about combination therapy. So when do we start combination therapy? If one of the therapy is not working, then we can combine them. The advantage is that there is enhanced efficacy because of the synergistic effect, but the disadvantage is that the risk increases as well as the side effects. So several studies have been done where they have combined various therapies, and then some of them have been found to be effective, some of them are still under study. Nowadays, our main focus is on lifestyle modification. We know that reading is a good habit, but excessive reading is also not good, and digital devices and increasing the outdoor activities. So study has been done to study the influence of environment and lifestyle on myopia. In Sydney myopia study, it was found that 2 hours of outdoor activities daily reduce onset of myopia, even if the kids have a lot of near work. And there is a dose-response relationship between how much time they spend outside and the myopia onset and also the progression. So when regarding the light, the outdoor activity is promoted because of the intensity of the light. Indoor, outdoor, they have more intensity of light, so that kind of have an impact on how the myopia progresses. So more myopic spherical equivalence ratio is seen, and longer axial length were associated with kids who spend more time using smartphones. Coming to optical correction, Mrs. Rosemary has spoken about the spectacles and all, but I'm just giving an outline. If optical can be spectacle or contact lens, we have single vision lens and myopic lens, contact lenses, soft contact lens, and ortho K lenses. Each of this management has to be tapered according to the needs of the child. So defocus, if the child myopes with relative peripheral hyperopia, we prefer defocus spectacle lenses or multifocal distance soft contact lenses and ortho K. Individual with high accommodative lag or esophoria for near viewing, we go for bifocal or progressive or EDOF contact lenses. Regarding ortho-K lenses, it gives a slight flatter base curve so that it kind of gives a compressive positive pressure on the central part of the cornea, which causes flattening. And when we do the staining, we'll have this bull's eye effect. And it was first used in 1965. So the advantage of this is that the child can wear this lens at night at bedtime, and then during the daytime they can be spectacle free, because this acts by working on in this part we can see after 14 days of use of ortho-K lenses, the central part of the cornea gets compressed. However, it is reversible, and the contraindication would be any eye infection, which is predictable. We won't use contact lenses. And the advantage is that once we stop the treatment, it kind of reverses back, so it's a reversible thing, and it's not age dependent. Anyone can use it. The disadvantage is that several visits are required, and it's not a permanent solution. Coming to myopia control glasses, which is the upcoming trend now. So bifocal and progressive additional lenses were used initially, but it was found that when studies were done, the outcomes of these two were comparable to single vision lenses, and so for progressive myope, usually not preferred unless in the criteria mentioned before. The principle of the newer glasses for myopia control is that in a normal spectacle, the central light rays will be focused on the center part of the retina, and the peripheral light rays will be focused behind the retina. So this kind of gives us stimulus. This hyperopic defocus, it gives us stimulus, and so it causes axial elongation. The principle of the newer myopic glasses is that when these glasses are used, so instead of causing a hyperopic defocus, the peripheral light rays will be focused in front, causing a slight myopic defocus. And this is achieved by using additional plus lenses. So different technologies are there depending on different companies. We have Beams, Halt, Care, and Dot. And basically whatever the company or the technology is, the principle remains the same. The central portion will be clear area ranging from 5 mm to 9 mm, while the peripheral areas will be plus lenses will be added. This will give a slight myopic defocus. So this is the type of lenses, and several studies have been done to compare the benefit of this to the single vision lens, and yes, they were found to be significant. So the advantage is that it's 62% effective. However, it's very costly, and the starting rate is around 7,000 going up to 25,000 depending on the power and the company. Some of the patients may not be able to afford it. The most studied pharmacological medication for myopia is atropine, and then the most common studied dose is 0.01%. Several studies has been done for that. Atom 1, atom 2, we don't have time to go into detail for that. Basically the exact mechanism is not known, but it acts by increasing dopamine and suppressing the eyeball elongation, or it acts on the scleral remodeling. The dose is OD, and emerging research we have two, that is red light therapy and methylxanthine. Red light therapy is we give it like 3 minutes twice in a day, and same mechanism, it acts by increasing the choroidal thickening and retinal thickening, which will kind of slow the axial progression. Then we have 7-methylxanthine, which is an adenosine receptor antagonist. It also induces thickening of the posterior sclera and collagen, and thus slows down myopia progression. But these researches are still underway, and the safety has several studies have to be done. It's just one study has been done. So myopia control glasses, it just slows down progression. It does not reverse existing myopia or eliminate the need. So all this myopia therapy which I have said, we do it for around 2 years of stability, or we stop it when they cross 17 years of age. And basically the takeaway from here is that it's crucial to modify each treatment according to the child's need. Thank you.
Thank you, Dr. Aunshi. That was a very elaborate topic, but she presented it in a very crystal clear way. So next the next speaker is Dr. Thomas Arun Varghese. He is a senior consultant working at St. Joseph's Hospital, Kanjirapalli, Alphonse Eye Hospital, Pala, Jacobs Eye Hospital, Ernakulam, and Vettam Eye Hospital, Perimpalli. Over to you, sir.
Good afternoon, ladies and gentlemen. At the outset, I'd like to thank Ksos 2025 organizers and Dr. Anjana Nair for giving me this opportunity. As previous speakers have spoken about the nuances of pediatric refraction, and I'd like to now speak to you briefly about how we can guide our parents and help them in choosing the right specs, right frame and lenses for their children. So this is the usual gadgets that we use in the case of adults. Of course, we look at the comfort and fit, the frame material, and you can, with this new gadget like the Opticom pad, you can get multiple measurements which can help you in choosing the ideal frame. But when it comes to pediatric, they are not very useful. Our children, as especially Rosemary had mentioned, the face structure, the size of the head, temple, and especially the shape of the nose in the case of certain children, the abnormalities, all these can affect the ideal frame that they can use. And of course, if they are not comfortable, they are not going to wear it, and you're not going to get the compliance that you desire. So a child's face is not just like a zoomed in adult's face. The various differences: one is the reduced crest height, the widened splay angle, larger frontal angle, the smaller bridge projection, small head and temple width, and of course you don't use a pantoscopic tilt usually in children. So dispensing frames, of course, when it comes to the facial and nasal structure, what is usually preferred is a saddle bridge type of nose, a type of saddle bridge in the frame, and also you need to ensure that there is a snug fit and that the frame doesn't come loose. You can use the riding bow. You can use a skull type of leg, and also you can nowadays you have these straps which can be used, which can be adjustable to ensure that the specs sits comfortably without being too tight or loose. A middle level bridge is better, and it should be a comfortable fit for the child, not restricting their daily activities. Of course, it should be fairly resistant to any hits and bumps. As you know, children are running around, and it should be an attractive color and design. And nowadays, you know, children have their desires, and if they're not happy, they're not going to wear it. Online, you see especially teenagers buying these large frames, and this is definitely not suitable in the case of our small patients. The benefits nowadays, we have these for small children, you have these wonderful frames, and they are very flexible, very light, comfortable, and also aesthetically appealing, and there's very minimal metal that is used, and the joints are very flexible. Recently I gave a prescription to a 6-year-old child, and the child was very good with the glasses, and the mother especially was very happy, because what we don't realize is very often they have younger siblings, and sometimes the younger sibling just takes the spectacles and then runs off and does all sorts of things with the spectacle, and the mother was very happy that it was still not broken and still in one piece. So the saddle, the silicone nose piece, all are very important. You can see this is a particular company. You can see the advertisement itself shows that the spectacles are very flexible and practically unbreakable. And of course, you also have the adjustable strap that can be used to ensure a snug fit. So now we have found the ideal frame. Coming to the lenses, of course, they have to be impact resistant, lightweight, and nowadays most have very good optics. It is good to give UV protection as well. And the different materials that we have now available is CR39, Poly, and MR series. And in case you have to give bifocals, especially for children with accommodative squint, then you can, when we have to give bifocals, make sure that it is not like in an adult bifocal segment, where the near segment should be a large segment in the case of pediatric patients. And where necessary, you should use a high index lenses to make sure that it is light and aesthetically appealing and comfortable to the child. Care of spectacles. Now they've chosen the spectacles and the frame. You should, from the beginning itself, you should educate them about the use of the spectacles in a good way so that it lasts. So removal of the spectacles, you can see, tell them not to remove with one hand, always use both hands to remove the spectacles. And sometimes you see children, even my younger daughter who used to wear glasses, she tends to just throw them away. Sometimes they sleep with the glasses on, all sorts of things that they do. So make sure when they take them off, preferably put them in the back in the case, all simple things, and not put them with the lens touching the surface, causing damage. And especially in the case of our children with astigmatism, whenever you when you review them, make sure you just check the frame, and this is what is known as the 4-point touch test. So you put the frame down as you see in the right side picture, and making sure these 4 points are touching on the surface, and that shows that the frame is in good condition. Especially in the case of astigmatism, as you know, the power may be correct, but any sort of misalignment can cause symptoms and also affect the quality of vision. So it's very nice to see that nowadays children have so much choice of spectacle frames. Also, coming to the care of the lenses, preferably wash them in running water, and also you can use these different sprays that are now available, and also microfiber cloth. I was just looking on the net, and there's this new thing that is seen. It's again made of microfiber, which again can be used to clean the lenses. So it's a very a simple topic, but a very important topic as well. So you can see the essential points is it should be a nice functional frame, appropriate safe lenses, and advise them on how to care for them. You can see this wonderful frames that are now available. And I started wearing glasses when I was in 5th standard, and I was, you could say, partially hyperactive child running around. I was in a boarding school, and the first 3 months I broke 3 frames. So my parents got me this big frame, you can see here, very thick, so that I couldn't possibly break them unless I really tried very hard. Thank you.
Thank you so much, sir. Even though it's very difficult for me to think you as a very hyperactive child, because you're very polite and poised. I can't imagine like that. But to be very frank, the topic was very well discussed. Lot of practical points. Thank you so much, sir. We are moving to the last topic, that is binocular vision anomalies in kids. Be dealt by Dr. Sanitha Satyan. She is a medical director of Vettam Eye Hospital, Puttota and Molandurthi, Ernakulam, and as well as performing as a pediatric ophthalmologist in multiple centers across Kerala. Over to you, ma'am.
Thank you, Anjana, and good afternoon, all of you. This is a relatively less discussed topic, so we wanted this in the IC because it is a very important one as far as the kids are concerned. Binocular vision anomalies affect coordination of the 2 eyes and disrupts optimal visual performance. So a child can have 6/6 and 6 vision, but at the same time child may have difficulties due to binocular coordination, and this can affect activities ranging from reading to navigation of complex environments. Binocular vision anomalies in children can be broadly classified as strabismic and non-strabismic. I'll not be talking about strabismic anomalies in this session. We'll rather touch upon more of non-strabismic ones, which again includes phorias, heterophorias, accommodative anomalies, and vergence anomalies. The whole point of the session is to prime ophthalmologists that there is something called non-strabismic binocular vision anomalies, and if we are cautious, if we are aware of it, we can actually guide them properly and give them much needed relief in their academic and other activities also. Accommodative dysfunction, we know it is results from difficulty in adjusting focus between the near and far distances. Convergence insufficiency is the inability to align the eyes properly when focusing on near. This is very common among children, and I'll be talking in detail about convergence insufficiency. As I mentioned, heterophorias are also included, and when there is disruption of fusion, there is a heterophoria, and this misalignment can cause visual disturbances. Binocular vision anomalies causes reduced visual efficiency. As I told, vision may be, as per the normal test, it might be normal, but the child has a reduced reading speed or gets asthenopic symptoms on regular activities. We should suspect some kind of binocular vision anomalies also. It can also cause occupational and social challenges. As I told, one of the most common and one of the most undiagnosed cause of visual efficiency problems in children is convergence insufficiency. So convergence insufficiency is a condition in which there is exophoria at near, orthophoria or low exophoria at distance, a receded near point of convergence, and reduced positive fusional vergence and low AC by A ratio. This might sound very technical, but in OPD also we can use some very crude test, I would say, like we are testing the convergence in this young girl. So as the pen comes close to the nose, okay, at this point you can see that one eye deviates outwards. That is because the subjective break point is when the patient is focusing on the tip of the pen. At one point, the patient can have diplopia. That point is called subjective break point, and then the point at which you see the eyes deviating, that is the objective break point. This all of us do in our OPD, and it is a test for convergence testing. This is testing for the near point of convergence using an RAF ruler. So at one point when the patient is focusing on the dot with the line, the patient can experience diplopia, and then you can quantify it also, which will help us to assign the child as having normal convergence or abnormal. Similarly, accommodation can also be tested using the RAF ruler. We are all familiar with this. Sorry. This is something called positive fusional vergence, which again comes in the definition of convergence insufficiency. So base out prisms are used, and the patient is focusing on a near vision chart. You go on increasing the magnitude of the base out prisms, and at one point the patient's fusional vergence reserves are over, and then she will have diplopia. That is how you test for positive fusional vergence. And heterophorias, you know, these are latent deviations, and this present a small amount of squints, which are often missed in a usual OPD evaluation. But if the child has a normal visual acuity testing with asenopic symptoms, always look for a small phoria. It can cause all these problems. And AC by ratio, we all know about AC by ratio. It can be tested in cases for diagnosing convergence insufficiency. Again, convergence insufficiency is primary and secondary. Primary being not associated with strabismus or refractive errors, secondary those associated with these both. It is quite prevalent. There are studies which say 3 to 5% of population, 5% of kindergarten students do have convergence insufficiency. And as I told, they present with eye ache, frontal headache, fatigue, blurring of words, difficulty to concentrate, even nausea, dizziness, and more towards the evening, because throughout the day we are using our convergence reserves, and all these symptoms usually appear towards the evening. So this is also an important question which you can ask the child, what is the timing of the headache like. And symptoms are inversely related to the degree of convergence insufficiency, which means if the child has a large amount of problem, the child may not even try to attempt convergence, so they may not have the symptoms. And you have to ask for the duration of symptoms, time of onset, nature of work, previous work, and any medications. And also the general well-being, lack of sleep can actually aggravate the problems. And usually we get children coming at the time of exams. A lot of sitting through the night for studies can cause all these problems to manifest. There is something called secondary convergence insufficiency, because if you have a high refractive error, they may actually decrease the convergence ability. Also acquired myopia, so they do not have a need to accommodate for near. So therefore accommodative convergence is reduced. So how to manage convergence insufficiency? First and foremost thing, we do an appropriate refractive correction. And the next thing is we'll be talking about vision therapy. And the rationale behind the whole thing is, there is different components of convergence, out of which there is a fusional convergence reflex, which is plastic, which means fusional convergence amplitudes can be increased. But how do you do that? By challenging the binocular visual system in two ways. That is how you do vision therapy exercises. And basically you can improve the fusional convergence by using voluntary convergence to facilitate fusional convergence. That is what we do in pencil push-ups when we use a convergence card or a CAT card. Another way is by provoking the fusional convergence by stimulating disparate retinal elements. So we all do this test, but technically these are the principles behind this. We can use a base out prism to induce fusional convergence. So there are different therapy tools in convergence insufficiency, like a stereogram, base out prisms, Brock string, lifesaver cards, eccentric circles. So this is a convergence card. You can see the girl doing the exercise. And this is a Brock string, which works on the principle of physiological diplopia. This is a lifesaver card. This is the eccentric circles. This is a CAT card stereogram. So most of us actually, when you see a child with a small heterophoria, most of us tend to diagnose it as convergence insufficiency. So I would like to say that not all small heterophorias or exotropias are convergence insufficiency. So because if you treat a convergence insufficiency with the proper exercises, they definitely will improve. And what kind of exercises do you give? This is the classical one which we give, pencil push-ups. So the most important thing when you advise pencil push-ups is that you have to advise them properly. The patient will have a lot of problems because of this esthesionopia, and whatever you convey to the patient, they will be doing it. So it's our responsibility to do it properly. I say this because most often it's not done properly. It's a very simple thing. So I'll just see the video. This is a CAT card exercise being done. So this is the CAT card stereogram in which you have two incomplete cats, one with the tail and whiskers and other without. So this is held at a distance and the patient is looking at the tip of a pen, which is kept midway between the card and the patient. So the basic exercise is bringing the pen closer to your nose and trying to focus only on the tip of the pen. Okay, and at no point we are looking at the CAT card. We are looking only at the tip of the pen and we are trying to see the cat on the CAT card stereogram as a single cat with whiskers and tail. Okay, this is important because what we are basically doing is we are keeping the accommodation at check and accommodation at stable distance, and then we are using convergence to may improve our convergence facility. That is how you treat it. Just see the video now. Okay. Now bring the tip of the pen closer and look only at the tip of the pen. All these times she was seeing the cat as 2. Okay. Yeah. At this point, she says that she is seeing it as double. And when you she was seeing it a single. And when you see it single, you hold it there for a few seconds, and then that is basically you are keeping your accommodation distance constant, and you are using only your convergence to see the cats. So that is how you do a proper CAT card exercise. And then you can again don't blink because again that automatic correction happens. Never look at the cat stereogram, only look at the tip of the pen, and then you have to fuse using your convergence to see the cats as single. So this is actually, this is similar to pencil push-ups, but we are having a target here also. So this is more recommended. So maybe you can see the video once again. Okay. Now it is single and hold it for some time. And again, then you can do the exercise maybe 5 times or 10 times depending upon the patient's state of convergence insufficiency. So ask the patient to do the exercise when the patient is fresh. So after all the work of the day, if you are trying to do it in the evening, they will have more problems. Actually, it will induce headaches. So once it is done properly, it will have a lot of very promising results, and there are a lot of patients coming to our OPDs with convergence insufficiency, and if you understand it properly and convey the right message, all these people can be treated very well. But at times what happens is patient will be doing like this, and what we improve is our biceps actually, not the convergence muscles. It is usually the conveyance of this is very different. So that is one take-home point which I wanted to convey. And now there are a lot of home therapy system tools also which uses accommodation and vergence exercises. This can be done in office or at home also. So these are also very efficient in improving convergence insufficiency. So I have just mentioned about the most important and most clinically relevant one, convergence insufficiency. There are other things like, especially because of the smartphone use and by children, there are a lot of problems with accommodation also, but I think it would be a too lengthy presentation to present all that. That's all. Thank you.
Thank you, ma'am. The topics are open for discussion. Any questions from the audience?
Question to Dr. Aunsi. So what is your practice with regarding prescribing the drops for myopia drops? Yeah.
So after the first evaluation, like I've seen a child for the first time, I'll follow them up at 3 months or 4 months. Then I'll follow them up at 6 months. At 6 months when they come, I will repeat the axial. Even if there is like slight changes, I would like to repeat the axial length, and then I'll see how, if there's any progression. If it is more than 0.5 or 0, then I'm like, sometimes I explain to the patient I would like to start with atropine, but most of the parents will be hesitant. So then after counseling them, I call them again for next after 3 months or 4 months, because they have already been sensitized with the use of atropine the first time. Most of them, they are willing. So I would start with a OD dose, 0.01%. And then after, at every visit, I prefer to take excellent, because that helps me to monitor. And the thing with this one, if I don't call them very frequently and they lose follow-up, then they stop using atropine. And so far I haven't seen rebound even if they stop, but I think counseling is important. So nowadays what I'm doing, I'm taking more time out to sit down and explain to the parents and show all the diagrams and see how the island is axial elongation is happening and how the medicine acts. Some parents, they have this thing in their mind, if we're putting eye drops, are we causing any damage, because it's a chemical, right? So then I also, along with that, in the first counseling, I'll give them the option of glasses. But when it comes to myopic glasses, because of the financial things, especially my patients, they would be like not willing to spend that much. And most of my pediatric kids, they break glasses every 1 month or 3 months, so it's not possible to have myopic glasses, especially in Indian scenario, where I think in foreign countries they have reimbursement and insurance covers most of the things. Here, so I really have to counsel them for the glasses. Yes. And I have kids who are wearing glasses, like I have some kids who are wearing DIMS. they are doing well, and they are more from the slightly higher status, so the parents don't mind, even if, because they don't have to put eye drops, so they think like, okay, they're happy with that. But yeah, so what about madam? What about your myopia, like progression?
I am still a person who does not use atropine for myopia control. So I think I'm not the person to talk about it. So.
I was a little bit reluctant to use, but then after attending a lot of conferences and after following a few of my patients, I also gradually started. I haven't gone to BD doses or 0.5% doses. I'm still sticking on to 0.1%.
Yeah, my concern is we do have some robust data, but we do have Indian data as well. But even now, the mechanism of atropine is not fully elucidated, and we are giving it long term for the kids. So I'm a little skeptical about using in the kids. So whenever a kid comes, when somebody's already started atropine, I don't discourage them, but I'm still waiting for more evidence, and the recent evidence has also shown some rebound. So that is also something which I don't do personally.
So that was what I was scared of when I started using, so then I was keeping a more closer follow-up.
Right.
So far, none of the kids have had rebound, touch wood, but
Right.
still, I would
Long-term follow-up is needed for that, and it might also have systemic effects, which we are still not very sure about. That's what. Okay, so we have some more time. For the interest of the audience, I would like to ask Rosemary, because she has been working with children with special needs, especially as she told, we work as a team in a rehabilitation center who attends to a lot of autistic kids. So what are the special challenges that you see in such children, and how do you deal with it in a visual rehabilitative perspective?
For autistic children, we കൂടുതലായിട്ടും ഡൈനാമിക് റെറ്റിനോസ്കോപ്പി ചെയ്യണം. ലൈക്ക് അവർക്ക് അക്കോമഡേറ്റീവ് പല ടെമ്പർ ടാൻട്രംസും അവരുടെ ബിഹേവിയറൽ ഇഷ്യൂസായിട്ട് നമ്മൾ പറയുമെങ്കിലും, ബട്ട് മോസ്റ്റ് ഓഫ് ദ ടൈം അത് അവർക്ക് CVA പോലത്തെ അല്ലെങ്കിൽ കോണ്ടെക്സ്റ്റ് ബ്ലൈൻഡ്നെസ് പോലത്തെ ഇഷ്യൂസ് ഉള്ളത് കൊണ്ട് നമുക്കവരെ മനസ്സിലാവാത്തതാണ് പ്രശ്നം, അല്ലാണ്ട് അവർക്കല്ല പ്രോബ്ലം. ഇപ്പോൾ ഞാൻ പറഞ്ഞു സ്പെസിഫിക് ലേണിംഗ് ഡിസബിലിറ്റി ഉള്ള കുട്ടികൾക്ക് മാത്സ്, ജോമെട്രി, ഷേപ്സ് ഒക്കെ വരയ്ക്കുമ്പോൾ ബുദ്ധിമുട്ട്, അപ്പോൾ അവർക്ക് സ്കോളാസ്റ്റിക് പെർഫോമൻസ് എന്ന് പറഞ്ഞിട്ട് അവരെ റെഫർ ചെയ്യും. ആൻഡ് ദേ വിൽ ബി ഡയഗ്നോസ്ഡ് ആസ് ചിൽഡ്രൻ വിത്ത് ലേണിംഗ് ഡിസബിലിറ്റി. പക്ഷേ അവർക്കൊരു CVAയുടെ പോസിബിലിറ്റി, അവർ നോർമലി ഡെവലപ്പിംഗ് ചൈൽഡ് ആയതുകൊണ്ട് ഒരു CVAയുടെ പോസിബിലിറ്റി ആരും സംശയിക്കത്തില്ല, ആൻഡ് നോബഡി ഇൻവെസ്റ്റിഗേറ്റ് അബൌട്ട് ഇറ്റ്. അതാണ് ഫസ്റ്റ് പ്രോബ്ലം. സോ ഇങ്ങനത്തെ കുട്ടികൾക്ക് യു ഷുഡ് ഗോ ഫോർ എ ഡീറ്റെയിൽ ഹിസ്റ്ററി, പെരിനേറ്റൽ ഹിസ്റ്ററി. എന്തെങ്കിലും റിസ്ക് ഫാക്ടേഴ്സ് ഉണ്ടെങ്കിൽ അതർ അഡീഷണൽ ടെസ്റ്റ് ഹാസ് ടു ബി പെർഫോംഡ്. അപ്പോൾ അവർക്ക് വിഷ്വൽ സ്കിൽസ് കുറവാണെങ്കിൽ ദാറ്റ് ഹാസ് ടു ബി എംഫസൈസ്ഡ്. അല്ലാതെ LD ഉള്ള കുട്ടികൾക്ക് സാധാരണ കൊടുക്കുന്ന ഒരു തെറാപ്പി സെഷൻ കൊടുത്തുകൊണ്ട് ഇറ്റ് മേ നോട്ട് ബെനിഫിറ്റ് ദിസ് ചിൽഡ്രൻ. ദെൻ ഇൻ ഓട്ടിസം ദ തിങ് ഈസ് അവർക്ക് ഫൈൻ ഡീറ്റെയിൽസിലാണ് ഇമ്പോർട്ടൻസ്. ദേ ഡോണ്ട് ലൈക്ക് സേ നമ്മളൊരു പിക്ചറിൽ കണ്ടിട്ട് യു ആസ്ക് ദം ടു ഐഡൻറ്റിഫൈ എ ഫോറസ്റ്റ്. നമ്മളോടൊരു കുറേ പിക്ചേഴ്സ് കണ്ടിട്ട് അതിൽ ഫോറസ്റ്റ് ഉള്ളത് ഏതാണെന്ന് ചോദിച്ചാൽ നമ്മൾ ഗ്രീനറി കാണുന്നത് നോക്കി പിക്ക് ചെയ്യും. ബട്ട് ദേ വിൽ ലുക്ക് ഫോർ ദി ട്രീസ് ഫസ്റ്റ്, ദെൻ ദേ വിൽ ഐഡൻറ്റിഫൈ ദ ഫോറസ്റ്റ്. ആ ഒരു ഫൈൻ ഡീറ്റെയിൽസിൽ നിന്നാണ് അവർ ഗ്ലോബൽ പെർസെപ്റ്റീവിലേക്ക് പോകുന്നത്. നമ്മൾ തിരിച്ചാണ്. ആ ഒരു കോണ്ടെക്സ്റ്റിലുള്ളവരൊരു വ്യത്യാസമാണ് അവരെ വ്യത്യസ്തരാക്കുന്നത്. അത് നമുക്കറിയാത്തത് കൊണ്ടാണ് നമുക്ക് അവരെ പല ബിഹേവിയേഴ്സും നമുക്ക് എക്സ്പ്ലെയിൻ ചെയ്യാൻ പറ്റാത്തത്. ചിലപ്പോൾ അവർക്കൊരു അക്കോമഡേറ്റീവ് ലാഗ് ഉണ്ടെങ്കിൽ അവർ കുറേ സമയം നമ്മൾ നിയർ വിഷൻ ടാസ്ക് തെറാപ്പി കൊടുക്കുമ്പോൾ, കൂടുതലും OT തെറാപ്പീസിലൊക്കെ അവർ പിന്നെ ബീഡിങ്ങും സ്റ്റാക്കിംഗ് ഒക്കെയാണ് എക്സസൈസ് ആയിട്ട് കൊടുക്കുക, ഐ ഹാൻഡ് കോർഡിനേഷൻ ഇമ്പ്രൂവ് ചെയ്യാനൊക്കെ ഉണ്ട്. ബട്ട് അത് കുറേ നേരം ചെയ്യുമ്പോൾ ദേ കനോട്ട് ഫോക്കസ് ഓൺ നിയർ ഫോർ ക്വൈറ്റ് സം ടൈം. സോ ആസ്ട്രോനോപിക് സിംറ്റംസ് അവർക്ക് അത് പറയാനറിയില്ല, തലവേദന എടുക്കണമെന്നോ കണ്ണ് സ്ട്രെയിൻ ആണെന്നൊന്നും പറയാൻ പറ്റുന്നില്ല. സോ ദേ ജസ്റ്റ് മേക്ക് സൗണ്ട്സ് ഓർ ബിഹേവ് ബാഡ്ലി. അപ്പോൾ നമ്മളത് ബിഹേവിയറൽ ഇഷ്യൂ ആയിട്ട് നമ്മൾ അങ്ങനെയാണ് തെറാപ്പി കൊടുക്കുന്നത്. സോ ഐഡിയലി വെൻ പ്രോപ്പർ ഒഫ്താൽമിക് ഇവാലുവേഷൻ ഈസ് ഡൺ ഫോർ CVI ആൻഡ് അതർ വിഷ്വൽ മോട്ടോർ സ്കിൽസ്, അൺവാണ്ടഡ് ടാഗിങ് ലൈക്ക് ഓട്ടിസ്റ്റിക് ബിഹേവിയേഴ്സ് എന്ന് പറയുമ്പോൾ തന്നെ ഒരു സ്റ്റിഗ്മയാണ്. അങ്ങനത്തെ കാര്യങ്ങളൊക്കെ അവോയ്ഡ് ചെയ്യാൻ അത് ഹെൽപ്പ് ചെയ്യും, പ്രോപ്പറായിട്ട് ഇവാലുവേറ്റ് ചെയ്ത്. ബട്ട് ഡെഫിനറ്റ്ലി യു ഷുഡ് ഹാവ് ഇനഫ് ടൈം ആൻഡ് പേഷ്യൻസ്. നമ്മുടെ ഒരു ബിസി OPD ഇറ്റ്സ് നോട്ട് പോസിബിൾ. ഡെഡിക്കേറ്റഡ് സ്റ്റാഫും അതിനുള്ളൊരു ടൈമും കൊടുക്കണം.
Thank you, ma'am. I think we are running short of time. It's the time for the next IC. I would like to thank the Ksos Scientific Committee and all my co-instructors for participating in the instruction. Thank you, the audience. Thank you.